So I'll go ahead and get started. How about one more talk? So my name is Teran. I'm the last speaker today. I'm grateful to be able to speak today. Also, I'm grateful for all the colleagues, my colleagues speaking before and their messages. And it's been a great day. I hope you enjoyed it. So we'll move forward. We'll talk about neuromodulation, but just a little bit more about me in case I haven't met you. But I'm a physiatrist. I practice interventional pain and spine medicine. And I've been with the practice about 7 years. So just to jump in, I don't have any disclosures. Objectives today are to talk about neuromodulation, what it is, what it means, and the definition, the uses, and indications going forward in the future. So in the past, electrical stimulation just as a whole is about modulating or controlling the nervous system. So in the early 20th century, there was devices that are meant to essentially try to modulate or control the nervous system. And you can see some schematics there about what an early TENS unit would look like. A lot of you are familiar with the TENS unit, which is a trans-electrical nerve stimulator, which generates electricity. And in this case right up here on the top right, you can see kind of an early one. And then the bottom right, you can see more of an updated one that we use. And these are out there all over. They used an earlier one back then. Really it was unorganized. And through time, it really was important. It was difficult to organize the electrical output to make any effect on the body. And so that's why there was very slow progress for quite a long time. Until you get up to about 1965, and in that there was a landmark theory, the gate control theory, and you'll see the slide there in the middle about what that theory means. And basically it's impulses in the nervous system. When you have a provoked stimulus, the fibers are carried by certain pathways, and that stimulus has to reach its point and to feed back up into the brain to interpret. And when you stimulate a separate part of that circuit, basically, you can actually disrupt the signal. And it's kind of like when you tap on something, you can actually stimulate and override the system. And so that was the gate control theory of pain in 1965 by Melzack and Wall. We know a lot more as time has gone on about that theory and how things have evolved, and it's more intricate than we think and that we knew back then. And then through time, we have devices that were first used to stimulate the dorsal column. So I'm jumping ahead here a little bit about other devices and using this knowledge that we've gained and able to modulate the nervous system. So in 1967, there was a neurosurgeon that started to use an external device that would be implanted with an electrode that would be to stimulate the spine and have potential therapeutic effect. From there, more devices are developed about 5-6 years later, where stimulation or electrical stimulation was used to stimulate the thalamus for treatment of facial pain, and also deep brain stimulation arose from this research. From there, TENS units were used in hospitals all over for conditions like chronic back pain, headaches, and gout, and that's more of the origin, more of the use of TENS units becoming more well-known. From there, 1976, we have Cook and Dooley, who introduced stimulation in the patient population of MS. And it helped improve pain and spasticity in these patients. And they were really looking at blood flow and to the extremities and how that would help. This led down that pathway for their research. In 1981, there was a first implanted spinal cord stimulator, and it was FDA approved for chronic neuropathic pain in 1989. And I go back just a second here. So this is just showing deep brain stimulation there as a way to utilize neuromodulation. It also shows some of the effects on the cardiovascular system using spinal cord stimulation, which we know from research. So jumping back broad, we get to what is neuromodulation. Non-pharmacologic therapy, delivering small electrical pulses to the pain-sensing pathways of the spinal cord, effectively altering the pain sensation, traveling to the brain. And you can see here, it's pretty interesting. This slide covers what's been approved for this therapy and what is going to be or is future direction for this therapy. You can see on the left there that the deep brain stimulation is there, cochlear implants, vagus nerve stimulation. I know, thank you for enlarging it. The uses in chronic pain are peripheral nerve stimulation and spinal cord stimulation. And spasticity is on there as well, and even incontinence. So future directions, I'll let you read that out. I won't read that for time, but it's certainly an exciting field. It's very broad when you can see that, but I'm going to kind of focus in on what we can do with the spine. So next slide is having to do with a spinal cord stimulator. So commonly referred to as dorsal column stimulation or spinal cord stimulation. This is a device that's placed with electrodes, leads, and it's placed in the epidural space to be able to communicate directly to the spinal cord. These electrodes are connected to a pulse generator, as you see there, and you can see an X-ray in the middle, what that looks like with the leads and then the connection to the battery. So the mechanism of this is it's a facilitation, and it's very complex, and we could certainly dwell on it quite a while. If you look there up in the schematics shown, and the interaction can be, this stimulation can be done at the dorsal horn as well as the spinal cord itself, depending on where those leads are placed. But essentially, it's to interact with the synapse at the substantia lannosa of the dorsal horn, where the interplay happens. And it essentially is stimulating and disrupting those signals that lead up into the brainstem and to the brain. Its purpose is to close that gate, as I mentioned in the gate control theory, but it's more complex than that, and that's what that schematic down on the lower half is showing, is that when you stimulate with those two prongs on the left, you're actually getting this field, and the field is interacting with the entire part of the dorsal horn and even further into the spinal cord itself, with disruption and essentially trying to modulate that nervous system response and that pain response. So there's a different mechanism between the types of pain that we treat with this therapy, and that is neuropathic pain is generally what we think of when we're trying to treat. We use stimulation in that way, but it's also been used for ischemic pain. And so the mechanisms there are listed, but essentially you're altering the neurochemistry, you're stimulating the suppression, you're actually suppressing the hyperexcitability of the WDR, which means wide dynamic range neurons. And there's some essentially neurotransmitters in there that you're essentially can inhibit and you can limit. And it's shown there a little further in detail. But for ischemic pain, it's actually altering the sympathetic tone. So next we'll jump to indications. So the indications for spinal cord stimulation are failed back surgery syndrome, which is sometimes called post-laminectomy syndrome. And both diagnoses, I don't think they encompass the indications completely. They don't describe exactly what's going on for patients. So I prefer to use persistent spinal pain syndrome. It's not yet an ICD, hopefully it will be, but we're trying to change the nomenclature to that because that's really what it is. Persistent pain in the spine, chronic, that could be after surgery potentially, but even before that as well. Other indications, complex regional pain syndrome, CRPS, otherwise other terms like reflex sympathetic dystrophy, RSD, peripheral ischemia, and angina. Those two indications more vascular. Usually we don't use this therapy in this country, but it is used in Europe. Contraindications for this therapy, infection, aberrant anatomy at the surgical site, uncontrolled illness, systemic illnesses, or bleeding disorders. Complications, I have to mention definitely about complications of this therapy, as there are risks, as there are in most things. And that is the leads can move, they can fracture. It's sometimes susceptible, but that's not very common. Infection is rare. Dural punctures, because you're in the spinal space, it takes expert skill and to do this therapy. Hematomas, though rare, they are an emergency when it comes to these stimulators. Trauma can happen, again, extremely rare, but there are case reports. And then the last two that are important to note as far as complications are the tolerance of it and the inadequate relief that can happen. And these things are known. Tolerance, sometimes it's reported anywhere between 20 to 40% over time that someone will develop a tolerance. When you look at the whole of things, I mean, certainly the body adjusts and there is a tolerance to most things that we do a lot of the time, as far as the pain world is concerned. So as far as to combat that, I put down here that a daily washout or reprogramming, having multiple waveforms are actually ways to help combat that complication or that tolerance developed. And then inadequate relief. So the European study at 1,000 patients in a 3-year period showed the explant rate of stimulator device was about 7.9%. About half of those people, it was due to inadequate relief. And rechargeable was a little higher than conventional. And this leads to the thoughts that how do you overcome this? Well, the trial period helps. Patient selection and screening helps as well. So I'll get to that in a moment. Right here. So patient selection for neuromodulation or spinal cord stimulation. Again, it's not an effective treatment for all types of chronic pain. As I said, the indications are there for persistent spinal pain, CRPS, and it really is about trying to figure out how much of the pain is related to nerves or neuropathic pain. Screening process is important. It's a full evaluation or consultation to figure out any infection. Do they have a pacemaker? Have they had appropriate imaging, labs? They do need a psychological screening. You want to prevent a situation where the patient will fail this therapy because there are untreated other diagnoses. And then also the duration of pain is important. Is this, acute on chronic? Is there some other reason for them that they wouldn't be able to respond to the therapy? And that shows in a meta-analysis in 2019 where there was intractable spine or limb pain related to various disorders seen in 1,000 patients. And then the increased odds of about 50% pain reduction compared to continued medical therapy. So it is a good treatment if selected the right patients. And it also showed in that study that high frequency and burst were associated with a greater benefit rather than the conventional, which is called paresthesias. So then I have a slide here about an algorithm that I like. I've shown this in the past, and I think it just encompasses, basically, I know it's very blurry, sorry for that, but it really is about the assessment and figuring out where the patient has neuropathic pain and what treatments are offered. And this is kind of a scale, so you take a history, you evaluate, you look at imaging, you go through a lot of what their treatment has been like, and then you try essentially figure out the characteristics of their pain. And if those characteristics are fitting more with neuropathic pain in that definition, then you go down an algorithm here about medication management, optimize their medications, what they're on, add a second line if needed, and continues down until see somebody like myself down here for interventional therapies, using other second or third line medications. Certainly all of this is done with the knowledge, like it is on the right, that this is a multidisciplinary team, that we're using a psychologist, a therapist, PT, physical therapy, occupational therapy, and certainly other specialists or primary docs for management of these patients. Adjusting mood, helping with their sleep, those types of things are all taken into account. But when that's not enough and that's not helping the patient, then spinal cord stimulation can be an option for them. So then we jump a little bit to the new indications, which these are very recent within the last few years. I've told you about the ones already approved. These have also been approved, and that is diabetic peripheral neuropathy. It's the most common neurologic complication of diabetes. It's a major cause of morbidity. It causes the gradual loss of integrity of the longest nerves, and it leads to a lot of disability, sensory loss, risk of foot ulcers, amputations happen. And you can see up there on the schematic about the difference between healthy and nerves damaged by diabetic peripheral neuropathy. It's very common, 34 million with diabetes. 20% of those patients have neuropathy. 45% are refractory to conservative management. So 2 studies here I want to bring up real quick is the first one, 2021 in JAMA Neurology, that really studied all of the treatments for peripheral neuropathy. And about 25% of the current treatments we have for it work well, which is very low. Nearly half of those treatments, patients quit in the first 12 weeks due to side effects and issues. So their summation of that article was that there needs to be better, safer, less expensive treatments. The next article listed there is Peterson, 2021, same journal, which showed which is basically a trial centered around stimulation for peripheral neuropathy. And 200 patients involved, a lot of centers. You really see 85% responder rate from this treatment, from spinal cord stimulation for neuropathy, 76% decrease in their pain scores over 6 months. They improved sleep, they took less medications, and there were only a couple of explants due to any infection or complications. And these were still patients that you can see the bar there that A1C was less than 10, which is a pretty high bar, as well as BMI was high, less than 45. So what I want you to take away from this was certainly that spinal cord stimulation can help and is effective for peripheral neuropathy. And also I mentioned at the very bottom there that as pain management specialists can be a big part of the treatment for this condition. And I think underutilized, certainly. As most would say, neuropathy is not a condition all the time that you send to a pain management specialist, but I think it should be. So finally, finishing up, a few more slides to go. New indications. Another one is refractory low back pain. These people have not had surgery. It's very common to have back pain. As we know, 1 in 5 adults will have it. It can be very severe, very persistent, and disabling. And the goal most of the time is to manage the pain, improve their function, maximize their coping skills, using a biopsychosocial approach. These things we know about treating back pain, the less aggressive sometimes. It's just axial back pain, and these patients are coming in. We know certainly guidelines have come out to show this, that non-pharmacological therapy is preferred. The goal is to improve, again, their function. But sometimes medication management is used, and it can help with symptoms, but it's not a long-term strategy. And especially in a lot of the guidelines, opioids should not be used routinely for this type of management of chronic back pain, because we know they're very limited in their response, and there's a potential for harm. So where do these patients go? What do we do for them? This trial in 2020, again, a pretty robust trial in centers, 15 centers across 2 years of follow-up, multiple etiologies for back pain, non-surgical candidates. They responded very well, 81% responder rate, 90% of patients achieved at least 30% relief, and their pain scores, you can see as such, decreased quite a lot. And this is maintained over a few years. And another thing to mention too was their reduction of opioid use daily. So neurostimulation, has improved in its ability to treat axial back pain, and that's because of the technology upgrades. The hardware advancements, the programming, the waveforms that we now know, the energy we can deliver to the spinal cord that's safe, and be able to do that with these new targets that I mentioned before, and the placement of the lead is different. So all of these updates have really helped us to hone in on another way that we can attack this chronic back pain issue that's really prevalent all around. These are minimally invasive treatments as well. They do have their risks, as I mentioned, but they can be a help for people that are suffering. So where are we going for this? The last slide I have for you today is what can we see in the future? And certainly the future is now, actually, for this type of treatment. We have what's called closed loop systems that are coming out. These systems are designed to maintain a pain inhibition that's optimal, that adjusts to the patient so often, 100 times per second. It's capturing, reading, and recording and responding to evoked potentials in the spinal cord, and those or the nerves that respond to stimulation, and they provide that optimized performance. So it's another way we can interact, know some feedback of where patients are, and see their response, and track that out over time is exciting. And we've seen these studies, they're certainly coming out by the month. And then finally, to talk about the technology. Technology has been such that it's very up to date. We can upgrade these systems. We can essentially upgrade them on the fly, put new programming in them that they're compatible, and that's been great as well. So that's all. There's my references, and I appreciate it. Thank you.